Hello everyone, thanks for joining our webinar today. The IASSS Asia chapter is proud to bring to you the Neurosurgery Talk by the neurosurgeons, Dr. Vikas Vazhayil from India and Dr. Vairavan Narayanan from Malaysia. Before we invite Dr. Vairavan to speak on epilepsy surgery, please let me introduce to you this esteemed surgeon from Malaysia. Dr. Vairavan is the head of neurosurgical services in the University Malaya Medical Center and head of internationalization unit in the Faculty of Medicine, University Malaya. He is an associate professor and consultant neurosurgeon in UM. He did his basic medical degree as well as master's degree in surgery in the National University of Malaysia. He completed his neurosurgical training in Addenbrooke's Hospital, Cambridge in 2012, acquiring the FRCS Neurosurgery Fellowship from the Intercollegiate Board of Surgery in UK. He spent a further 6 months in the same year doing an honorary fellowship in epilepsy in University College London. He was recognized as a Malaysian National Specialist Registry Gazetted Consultant Neurosurgeon in 2013. His clinical interest lies in neuro-oncology, epilepsy, and traumatic brain injury. He works closely with the adult and pediatric neurologists in UM and has built up a successful epilepsy surgery unit which screens an average of 50 patients a year, of whom about 20 undergo surgery. With his fellow neurosurgeons and neuro-oncologists, he also runs a dedicated neuro-oncology unit which provides the highest standards of care for brain tumor patients. Without further ado, let's welcome Dr. Vairavan. Please note that the recording of the webinar started 5 minutes late. We sincerely apologize for any inconvenience caused.
And the problem with this is usually it's a one-way street. Once you've taken up surgery, it's very difficult to go back. So the decisions you make is going to affect the lifetime career. So it's always a very confusing point. Which one do I do, right? And when it came to, this is something you'd be faced with. Do you take up something like family medicine or plastic or orthopedics, surgical fields, etc.? And as a medical student, I was in that point. I had completed my medical school. I had come out as a house officer. And there are people who might tell you, oh, I knew I wanted to be a neurosurgeon from the beginning. I was not very sure. To be very honest, I knew I wanted to do something which involved surgical fields because I like doing things with my hands. I wanted to see the results immediately. I didn't mind the hard work. So I thought surgery was probably the most appropriate field for me. And to be very honest, neurosurgery was something I kind of fell into, right? I probably decided to do surgery somewhere along towards the end of my medical school and when I started my housemanship. And I'll just share a little bit of my journey itself, right? I was born in a small town in Malaysia, and I went to school in what is called one of the local universities, the National University of Malaya. And subsequently, I did I spent 2 years as a houseman in a very rural hospital called Kota Baru. I did come back to do my medical officer as a medical officer in emergency medicine and subsequently in surgery in Kuala Pilar before I started my my training in postgraduate medicine in Masters of Surgery. So I went back to National University, my alma mater, to do Masters of General Surgery. Once I finished that, only then I took up neurosurgery. So by now it's already about 10 years and I had taken up neurosurgery. I joined University of Malaya, which is where I'm working currently. I spent 3 years there and subsequently I went off to Cambridge in UK. I spent another further 2 years in Cambridge and another year in Queen Square, National Hospital of Neurosurgery and Neurology to do my epilepsy surgery. So in total, by the time I had come back as a consultant, I had spent about 19 years, 1 year housemanship, 3 years MO, 4 years Master of General Surgery, further 3 years of training locally, and another 2 years overseas, 6 months of fellowship. It's a long journey. It's a very, very long journey. So I had started off as a fresh-faced 20-year-old going into medical school. By the time I became a consultant, I was pretty jaded, but it was the start of my career. And so the journey itself took me 20 years. The reason I'm putting this up is because it is something Surgical training specifically is something you have to be ready for the long haul. It's not something that you do within 5 years. You do something as simple as an MRCP going to pediatrics or MRCOG going to ONG. Surgical training is very long, especially if you're going to do something subspecialized, because I wanted to do general surgery, subsequently neurosurgery, and then I wanted to subspecialize in epilepsy surgery. That whole process took a very long time. Do I regret it? I don't. I actually am quite happy to have done what I did. But during that process, that 20 years was a very difficult time for me and my family. Because you must remember that 20 years is when we are young, we're getting married, we have children, we have young children, we have financial commitments. So you have to balance all of that. And it was a difficult period. But if you actually, persevere, I think you can actually, reap the benefits later on. So why neurosurgery? I mean, neurosurgery itself is a specialty which a lot of people either shy away or look up in awe. It's a very difficult specialty, but it is necessary and important. It is frequently life and limb as well as soul-saving surgery. It may involve hours, but odd hours. It may involve difficult times, but you can make a difference. And more excitingly, the brain is the final frontier of exploration in human biology. We know everything about the heart, we know everything about the muscles, the bones. The brain is still something of a mystery. So for people who are interested in actually doing something new, actually pushing the frontiers, the brain is where you can make a difference. And these are the kind of reasons that should propel you to do neurosurgery. There are so many books out there on neurosurgery. In fact, disproportionately more than any other field. Because neurosurgery always attracts the glamorous people, the most exciting people. I mean, obviously, it's something people talk in hushed tones about. So neurosurgery has got the most number of social media presence, as well as a lot of urban legends associated with it. And if you read them, you can either feel in awe of the surgeons who have come before us, or we can get put off by the number of hours and the amount of difficulty they had to go through. I would say do neurosurgery because you want to make a difference, not because you get attracted by the glamour or the social media presence, etc. Okay. Going on to neurosurgery itself, neurosurgery is the clinical management of patients with surgically treatable conditions of the central and peripheral nervous systems. You must remember that almost 50% of our caseload is emergency and trauma cases. This includes traumatic brain injury, accidents, emergencies, etc. The other 50% is usually the elective cases we do, from oncology to spine surgery and etc., all the other surgeries. Because of the nature of the surgery itself, it is a very consultant-led specialty compared to most others. So as a medical officer, as a trainee, you would probably end up doing what the consultant has decided rather than what you can do on your own because of the complexity of the cases itself. And within neurosurgery itself, we have now become much subspecialized. We actually have got so many different subspecialties. And in fact, we are so subspecialized, so much so that some of us don't do the other subspecialties. Even though we are trained in everything, I don't do skull-based surgery. I don't do much of spine surgery. My primary work currently is epilepsy surgery as well as neuro-oncology. I don't do everything else. And it is good in some ways because the better we get at certain subspecialties, the better our outcomes are, the patient safety improves, the results improve. And that's why subspecialization is actually important in the future. The common pathology we usually deal with includes trauma and head injury, brain tumors, both benign and malignant, intracerebral bleeding, both spontaneous as well as aneurysm and vascular malformations, hydrocephalus. This is something else we do quite frequently, as well as spinal tumors and spinal degenerative disease. These are the common specialties we deal with when we talk about neurosurgical diseases and spectrum. Of course, we do have the other a little bit more exotic specialties, including movement disorders, intractable pain, peripheral nerves, as well as epilepsy. These are not as well known or as common as the earlier diseases, but they're still equally important, and it is a necessary specialty. So who should do neurosurgery? Anyone who wants to do neurosurgery, as much as any other doctor, has to be caring, compassionate, focused, and passionate. You have to have good manual dexterity. Unfortunately, this is a necessity for anybody who wants to do any surgical skills, more so neurosurgery. The millimeter of dexterity, the ability to actually react quickly in time, makes a life and death decision in neurosurgery, where we actually have to deal with minute bleedings, vessels, important structures within within millimeters of each other. So manual dexterity is extremely important. You must have excellent hand-eye coordination. You need to be able to look into a microscope which is above you while working below onto the brain itself. So that hand-eye coordination is extremely important. You have to be able to acquire, retain, analyze, and act on huge amounts of information all at the same time. While this may sound, like something difficult, you get used to it. Because you have to continuously process information and continuously make decisions while you're doing surgeries, or while you're actually taking your patients through the whole clinical reasoning process. So you need to be able to do this continuously. Of course, this is what keeps a lot of people off from neurosurgery, which is the ability to work long hours with minimal fatigue, or minimizing the amount of fatigue. Long hours is something we get very used to as trainees, especially. I used to stay in the hospital for 2-3 days at one go and come back home after the third day. But things get better as you become more senior. By the time I became a consultant, the amount of hours was more manageable. At this point in my life, it's much more manageable. I can actually decide when I want to do surgeries, how I want to do surgeries, and I can manage a lot of these things pretty well. So these are usually the kind of things you have to deal with in the earlier part of your training, not later. And you must be willing to put in the hours. The training part of the career, as I mentioned earlier, is probably the most difficult period of your time in neurosurgery. Just to put in perspective, this is, if you want to become a neurosurgeon, you need to know what your patients are actually looking out from you. They're not looking out for the most clever and the most brilliant doctor. What they want is an empathic doctor who's a good listener, who's compassionate, who's humble, competent, determined. Nowhere here do they say they want the most brilliant doctor who's got IQ of Einstein or anything like that. What they are looking for is a caring, compassionate doctor. And that's what we have to train ourselves to become. We have to be empathic. We have to understand that the patient is coming to you at the lowest point in their life, and you are here to help them, we don't become doctors for ourselves. We become doctors for the patients. They should be the center of your being, of the reason for your being, right? And that's why it is important that you are empathic, you are compassionate, you're humble, you're competent. That is much more important than you are knowledgeable, you carry encyclopedias of knowledge within your head. Please do not do neurosurgery if you think it's for the glamour, the glory, the money, the power, which all will come in time. But these are side effects rather than the primary goal of neurosurgery. A lot of the times, neurosurgeons are considered workaholic egomaniacs who actually want things only their way, and who push people around, who bully people. It's not really the kind of thing we want to project anymore. Maybe 50 years ago or even 30 years ago, it may have been okay. At this point in time, I don't think this kind of things will be tolerated in your workspace. And we don't want to encourage our trainees to do things like this. What is the working life of a neurosurgeon like? I mean, surgery obviously is the most important bit of why you do neurosurgery, right? And surgery is fun. I still, after so many years, I still enjoy going into my theater, doing the cases. actually seeing the results of my cases, seeing the outcome of my patient, seeing that the patient is actually able to, a patient who was having hemiparesis, who actually goes back home well, who was having seizures, with the seizures completely controlled. It makes your day when your patients say thank you at the end of the day and something goes well. That patient interaction is actually good. If you actually put in the work, then the patient interaction actually sustains you throughout your day. Of course, the actual surgery itself and the equipments we use and the seeing the technical bits work out, that's good as well. But there is always the challenging bits, which is the diagnosis and the management, clinical management. Neurosurgery, more than a lot of other surgeries, are usually much more difficult, and it carries a mental toll, both on the patient and the surgeon. The surgeries themselves can be very long, technically difficult. It can be emotionally draining, especially when the results don't work out the way you want it. And frequently, the results can be devastating, even with the best care. And this is due to the nature of the disease itself. I'm going to talk a little bit about the neurosurgical training in Malaysia. I know there are a number of people from overseas, but Amanda asked me to touch a little bit about this, so I'm just going to touch a little bit. Basically, there are multiple pathways to become a neurosurgeon in Malaysia. We from I'm in University of Malaya. We offer a Masters of Neurosurgery, which is a 4-year structured program, which will lead you to become a recognized neurosurgeon in Malaysia itself. And the pathway, I guess this will be very similar to any international candidates as well, but this is specifically for the Malaysian candidates. Once you have qualified, you have to do a 2-year house officer rotation in all the various subspecialties. Subsequently, you have to spend a further 2 years as a medical officer. Usually, this is within the Ministry of Health hospitals. And then you enter into specialty training. There are 2 primary pathways to specialty training: the local master's programs, which are 4-year structured programs, or the parallel pathways, which are usually the UK-based, UK and Australia-based fellowship programs, MRCP, MRCOG, FRCS as well. Once you have completed that, you come back and join the Ministry of Health, at which point you're gazetted as a neurosurgeon. Specialty training itself, I think I don't really want to go through in this, but as I mentioned earlier, surgical or medical base. Surgical base, you've got all the multiple specialties, and we have got direct entry program to neurosurgery now. So the various specialties I've noted here are available as subspecialties within our Malaysian training programs. If you need further information, you can always drop me a mail. This is for the Malaysian candidates, which I'll put up later. So, as I was mentioning, the direct entry program, Masters of Neurosurgery in we had our first, we are a relatively new program. We had our first intake in 2019, but we have been doing neurosurgery for the past 20 years through another university in USM. And we take about 4 to 6 trainees per year. The number of trainees is limited mainly because, again, the nature of the surgery limits the number of people who can be trained. And we want to make sure we get quality trainees. So we limit it to 4 to 6 trainees per year. I will skip this. Yeah. Going a little bit into other things, including the median starting salary. This is from US, 2015, 8 years ago. So things may have changed now, but I don't think the pattern of this has changed. And if you look at it, most of the surgical specialties are at the higher points of earning capacity. Neurosurgery is second here in US. In Malaysia itself, neurosurgery is usually either the first or second, along with cardiac surgery. So usually the surgical fields have got the highest median starting salaries compared to the medical fields. And this is probably applicable across the world. But you must always remember malpractice, medical legal issues. They are usually related to surgical fields as well. And if you look at the malpractice claims in the US, again, this is in 2017, I think, neurosurgery was the highest, followed by cardiovascular surgery, general surgery, orthopedic surgery, etc. So surgical fields carry a lot more burden in terms of medical legal suits, etc. So taking up something like this, you have to be very careful with what you deal with. You have to be, able to deal with patients properly, able to take on issues and actually deal with your patients in a way where you can minimize malpractice, etc. What about burnout? This is something we have been talking about quite frequently recently, especially after the pandemic came about. Surprisingly, this was reported in JAMA in 2018. Surprisingly, neurosurgery is actually quite low down here. There may be various reasons for this. Neurosurgeons, when you go into neurosurgery, they actually like what they're doing. So I think even though their work-life balance may be at stake, the burnout rates are actually much lower than most other specialties. If you look here again, this was in that same article. You look at neurosurgery, actually the work-life balance is the lowest among all the other specialties, but burnout rates are also among the lowest. The top left-hand corner, that's the best place to be in because it's a good work-life balance and minimum burnout. While the bottom right-hand side bottom is the worst place to be in. It's got the highest burnout rates and the lowest work-life balance. So among work-life balance, neurosurgery is poor, but burnout rates are low. As I mentioned, neurosurgeons probably like what they're doing. They don't mind the fact that they spend more time at work, and that probably leads to where we are here. So even though work-life balance is low, we don't really get burnt out as often. Coming back to summing up my journey itself, right? It took me about 15 years from graduation to become a consultant. But as I mentioned earlier, one of the things that usually gets affected is your work-life balance in neurosurgery. And it is very important that you try to, now 20 years down the road, you try to balance your life with your work, because life is not just about going to the theater, operating on patients. It's also about having good friendships, having a good mental strength, keeping yourself healthy. As you get older, standing in your microscope for 6 to 8 hours actually can lead to a lot of fatigue and stress, and you won't be able to do your work well. So having a healthy lifestyle, maintaining your body, eating well, nutritional, having friends, having mental, so that you are protected from mental stress. These are all equally important as work itself. And that's why now, 20 years down the road, I can tell you, I don't regret doing neurosurgery, but I would probably have maybe paid a little bit more attention to my work-life balance in my training years. I'm trying to correct that now. And whenever my trainees come up, I tell them, please make sure you maintain a good work-life balance from the beginning itself. Don't wait until it's very late and then try to catch up on that. You don't have to be brilliant to be a doctor. You just have to be hardworking and be compassionate and kind. I think that's what makes good doctors. And I think as long as you're willing to put in the hours, you're willing to be hardworking, I think you will make a good neurosurgeon. So that's the first part of my talk. Saad, do you want me to take any questions now, or can I just go quickly to my second part? You are muted, I think.
Thank you, Dr. Vairavan. That was such a detailed discussion on the pathways. You can move on to the next one. We will take the questions at the end.
Right, great. Okay, so the second part of my talk is on the epilepsy surgery. I think it's, let me share screen. I think it's a very niche topic that Amanda asked me, because epilepsy surgery is something I do, but it's a very, very uncommon and a very small area. But I think since she has asked me, I'll share a little bit. I probably won't go much into detail about this. And again, just like earlier, if you all do need to ask more things, my email is there. You can always contact me later. right? So epilepsy surgery is a surgery that is performed to remove epileptogenic tissues to control seizures. And seizures itself, this is a landmark paper in the New England Journal of Medicine. This was published in 2001 by VB et al. And this paper very clearly shows that patients with surgery do much better than patients, seizure patients, epilepsy patients without surgery. And this is something we have kind of dropped the ball on in the last 40, 50 years. It's only in the last 20 years that we've suddenly woken up and said, epilepsy surgery is a very important subspecialty in neurosurgery, and we as surgeons have to push this agenda through, because the neurologists are still very reluctant to look at surgery as a treatment of first option. In fact, most neurologists consider surgery as treatment of last option. I think it's time for us to move that whole conversation to treatment as first option. And that's what I've been trying to do here in Malaysia. And I think that's what a lot of surgeons have been trying to do all over the world as well. And this paper clearly tells us why it actually makes a difference. I mean, the patients in the surgical group, if you notice here, actually have got a much better outcome, 38% seizure freedom, compared to patients in the medical group who only have 3%. And that is very sad for patients with epilepsy, which is a chronic disease which is debilitating and can have a significant socio-economic impact on the patient as well as their family. So in this talk, I'll very quickly talk about the need for epilepsy surgery, as well as established surgical techniques and the new surgical techniques that are developing, which will make a difference in epilepsy surgery itself. As I mentioned, there's still a lot of people who are very skeptical about epilepsy surgery. And the misconceptions are things like all drugs need to be tried. Normal MRI is a contraindication for surgery. Surgery is not possible if primary or motor cortex is involved, or eloquent cortex is involved. Surgery will make memory worse. Patients with focal epilepsy and focal lesions can have the lesions removed without pre-surgical evaluation. These are all misconceptions that are being peddled. And surprisingly, this is sometimes peddled even by good neurologists as well as some neurosurgeons. These have been proven multiple times by evidence-based medicine that epilepsy surgery is actually useful, effective, and both cost-effective as well as has got good outcomes. And again, we have proven very clearly that seizure freedom is unlikely after 2 drugs have failed. And sometimes we got patients who have been on 2, 3, 4, 5 drugs, and they're so drugged out that they are non-functioning. And these patients will do much better with epilepsy surgery. So this is the major surgical gap we have. And that's one of the reasons why we don't really have much of these epilepsy patients coming to us for surgery. And we have to change this paradigm. The criteria for epilepsy surgery is quite simple. 1974, Walker came up with these criteria: drug-resistant seizures, frequency and severity as to cause significant social and medical disability, reducing or stopping seizures will result in significant improvement in quality, and there must be an acceptable risk-benefit ratio for surgery. Of course, we have now modified them. There's a demand for early surgery, especially in temporal lobe epilepsies, which actually can lead up to 100% seizure freedom. There's also the so-called palliative surgeries, which are things like corpus callosotomy and hemispherectomies or hemispherotomies, which are becoming much more common. And there is an evolving indication in children, especially with the advent of genetic assessment of syndromes, various epileptic syndromes. Of course, things like focal and regional seizure onsets are now completely curable in patients, irrespective of whether they are in eloquent area or otherwise. There are a few concepts of epileptic zones that need to be understood before we move into epilepsy surgery itself. We have to understand the concept of what is an epileptic zone, what is the irritative zone, what is the lesion, and the symptomatic zone. I think this picture will show you clearly. So an epileptogenic zone is where the epilepsy actually is originating from a biological point of view. But the seizure onset zone may be much bigger, while the symptomatic zone may be elsewhere. We need to understand these concepts so that the surgery itself can be performed in a way which is able to control the symptom as well as the seizure. Otherwise, we will not be able to have complete seizure freedom. Right, let me move on. And seizure freedom usually depends on removing both the seizure onset zone as well as the irritative zone which is around it. If we do not remove the irritative zone, seizures can persist. And these are concepts which we must understand before we proceed into epilepsy surgery itself. The current treatment options are quite straightforward. We've got temporal lobe epilepsies, lesional epilepsies, especially low-grade gliomas, cavernous malformations, which do well with lesionectomies or even lobectomies where necessary. And then we've got the non-temporal lobe epilepsies, that is frontal lobe, parietal lobe, etc. The cingulate epilepsies, and focal cortical dysplasias. These will do better with, you can try lesionectomies, but they do better with hemispherotomies, MSTs, as well as disconnections, callosotomies. In rare cases, we do put in vagal nerve stimulators to reduce the impact of seizures itself. There are a lot of new developing techniques, including radiosurgery, laser ablation therapy, which is becoming very excitedly discussed, radiofrequency ablation, endoscopic hemispherotomies, deep brain stimulation, SEEGs are stereoelectro-EEGs driven multilobar resections, and responsive neurostimulations. These are all new and developing surgical techniques which we are using for epilepsy surgery. Of course, there's also stereotactic stem cell and gene therapies which are being investigated but not in clinical practice yet. I'll skip this. So I'll just talk very briefly about standard surgical approaches. Temporal lobe epilepsy, that's the most common epilepsy surgery we perform. Usually it's due to mesial temporal sclerosis, which is basically this head of hippocampus which shows sclerosis here. And that sclerosis actually will cause, will be the seizure onset zone. And these patients undergo anterior temporal lobectomy, which is usually at the temporal lobe. We open up the temporal lobe and go into the mesial temporal area where the hippocampus as well as the amygdala is removed frequently. Of course, there are various ways of doing it. The standard way would be an open anteromedial temporal lobectomy, amygdala hippocampectomy, but we also have got selective amygdala hippocampectomy as well as endoscopic amygdala hippocampectomy. These are various ways of doing it, but at the end of the day, the primary aim is to remove the head of the hippocampus as well as the body and part of the tail of the hippocampus. So you would actually go into the mesial area, the medial temporal area, and remove the head, the body, and go up to the tail here. The outcomes for temporal lobe surgeries, almost 70 to 80% of patients are seizure-free at 2 years, which is much better than medical treatment. And this unfortunately declines about 50% at 5 years, mainly because of the seizures can come back due to various reasons. The brain itself is very epileptogenic, and once you have had seizures, the seizure can actually either move to the opposite side or to other areas, and you can develop recurrent seizures, and this can happen up to about 50% of our patients at 5 years. The long-term seizure outcome, depending on where you're operating on, the temporal lobe has got the best outcomes. More than 2/3 of them will be seizure-free, while the frontal lobe has got the poorest outcome at 27%. And this has been quite well known for a long time. Again, this is probably due to the misidentification of the seizure onset zone as well as the irritative zone, as I mentioned earlier. That's why it's very important to identify all the various zones and to remove the epileptic zone appropriately. And complications due to epilepsy surgery. This was a paper which actually looked at a meta-analysis which looked at 5,000 over patients over 32 years. And they divided them into two epochs. One was 80 to 95, and the second one was 95 to 2012. And if you look at it, I just want you to concentrate on permanent deficits, temporal lobe. 1980 to 95, we had up to 10% of permanent deficits, while 96 to 2012 is gone down to less than 1%. So surgeries have become much more safer. And this is across the board, from transient deficits, wound infections, hematoma, CSF related, all of them have gone down. Transient deficit has gone down from 40% to 5%. And this is, of course, it is seen in all surgeries, but more so in epilepsy surgery. As we become more comfortable with the surgery and our technology improves, the amount of complications has reduced. This is why I insist that surgery is not an option of last resort. In fact, it should be the option of first resort for patients with chronic seizures. In itself, this is our last publication, so I have not updated the publication, but up to 2018, we had done more than 98 patients. And out of these patients, I think our seizure freedom at one year was up to 60%. And this is Engels 1 classification. If you consider Engels 1 and 2, it reached up to 70%. And at 3 years, we had Engels 1, 2, and 3 up to about 40% outcome, complete seizure freedom. Now, moving on to developing techniques, newer techniques which are involved with epilepsy surgery. One of them is hemispherectomy. Hemispherectomy is basically in patients, in young children who have got hemispheric abnormalities which cause intractable seizures. And previously, we used to do anatomic hemispherectomy. That means half the brain used to be removed. And this moved on to become functional hemispherectomy, Rasmussen's hemispherectomy. And now we actually do very limited, minimal removal, but extensive disconnection. And in my center, I do endoscopic hemispherectomies. Basically, we actually make tiny holes at the top of the head, and we use an endoscope to actually disconnect half of the brain. Basically, as you see in the last set of diagrams here, we actually disconnect the frontal, parietal, and temporal lobe from the inner structures, and thereby reduce the amount of seizures that are being propagated from one hemisphere to the other. These are usually done in young children because the young children have got the ability to, neuroplasticity allows them to gain back most of the lost function due to this hemispherectomy. So even though these patients, I mean, at the younger age, when they haven't developed their hemiparesis yet, they actually can get back to near normal life. In fact, out of the 11 cases, 7 of my patients are completely seizure-free and back to normal life. They're walking, talking, going to school, etc. We did have one major complication out of this 11 case. It was a child with hemiplegia due to thalamic venous infarct. But that was the only major complication I've had in the last, I've been doing this now since 2017. So in the last 6 years, that's the only major complication we've had. The other thing we do now is grid and electrode insertions. So grid insertions are usually when we do a large craniotomy, we put in these electrodes, and then we close up the brain, put them in the ward, monitor them for anywhere from a week to 2 weeks to identify how extensively the seizure onset zones are and how much needs to be resected. This has now moved on more into SEEG-driven multilobar resections. So SEEGs are stereo electro EEGs. Basically, what we do is, if you look at the previous one, what we do is we actually put in electrodes into the brain under either a frame or a robot guidance. And these electrodes are actually within the brain, and they continuously monitor the brain activity for seizures, the seizure onset zones, irritative zones, symptomatic zones, etc. And once this is done, we then go back in later to remove the area involved. And in again, we have done 18 patients so far with frame-based EEG insertion. And each patient gets anywhere from 6 to 14 electrodes. The duration of surgery is about 4 to 6 hours. They are kept in the ward for up to 2 weeks. And out of these 18 patients, 14 of them underwent lobar resection. Another 3 underwent radiofrequency ablation. One of the patients we could not proceed because he actually had bilateral bilateral involvement, and usually we can't really resect bilateral hemispheres. So that one patient, unfortunately, we did not offer surgery. But out of the 18, 17 underwent surgery, and 13 of them had angles 1 or 2 outcome, which is 72% of our patients. These are patients who would be defined as chronic refractory epilepsy, and usually considered palliative. I mean, most of these patients were having anywhere from 8 to 10 seizures a day. In fact, one of my patients actually was having about 25 seizures a day. So they didn't really have much of a quality of life until they underwent the surgery. I'll just skip this. Yes, frame-based radiofrequency lesioning. That's another one I was talking about. This can be done for any of these focal lesions, including mesial temporal sclerosis, focal cortical dysplasias, hypothalamic hamartomas. Hypothalamic hamartomas specifically is something I've done a number of cases for, and with very good results. These are patients who develop gelastic seizures due to this large hamartoma which develops at the hypothalamic area. Surgical excision is usually carries a heavy morbidity due to the fact that it's connected to the hypothalamus, and these patients can have significant hypothalamic dysfunction if we try to resect this. So instead of that, we do radiofrequency ablation, and we have not had any complications, any hypothalamic dysfunction among our patients. 4 of them have angles 1 outcome, 1 has got angles 2 outcome. Radio surgery. Let me just move on very quickly to laser ablation therapy. Laser ablation therapy is something very new. It's basically insertion of an electrode under MRI guidance into the lesion, and then using a laser to ablate it. Very similar to radiofrequency, except that it is done in real time. And currently, it's only available in primarily in US and Europe. It has not really come to Asia yet. But this is a technology that actually something I'm looking forward to, because I think this actually can make a lot of difference for patients, because it's real-time lesioning of an epileptic source. And it has shown, based on the published papers, it has shown reasonably good results, at least comparable with surgery. So we can actually offer our patients these things, these therapies with minimal surgical morbidity. And that's why I'm looking forward to this becoming more widely available. Yeah. So I'm down to the last slide of my epilepsy surgery talk itself. Epilepsy surgery is very much a multidisciplinary specialty. You can't do this as a neurosurgeon alone. You need a good team of neurophysiologists, neurologists who specializes in epilepsy. You need a good neuroradiologist who's able to look at the MRIs and tell you whether these lesions, which ones are actually the symptomatic or the seizure inducing lesions. As I mentioned, a neurophysiologist, a neuropsychologist again. So we have got all of these people who have come before a neurosurgeon, and these are as equally important to a neurosurgeon. You have to work with them so that your patients actually can achieve good results. And that's why it's important to have a good multidisciplinary team if you're embarking on epilepsy surgery. So I'll finish this with what I usually tell my trainees. A careful and knowledgeable pre-surgical evaluation of candidates of epilepsy surgery is probably the most important step in getting the outcome. It's not so much how you do the surgery, it's getting the correct patients, identifying the correct lesions, and then doing the correct surgery. That is what is most important. And that is what is going to lead to good outcomes, patient satisfaction, and hopefully the surgeon's satisfaction as well. Right. Thank you very much.
Thank you, Dr. Vairavan, for giving such a detailed talk on the epilepsy surgery. So we don't have many questions in our chat box. There is only one question. So may I know if people who have had LASIK or any type of refractive correction surgery are able to be a surgeon? I think it's more related to the discussion we had earlier, not specifically related to epilepsy surgery.
Sorry, I didn't get the question. Can you tell me the question again?
Yes. So basically, they are asking that if someone has underwent a type of a refractive correction surgery, such as LASIK, are they able to become successful surgeons?
Of course you can. Refractive surgery should not stop you from being surgeons, right? Remember, I told you it's not your ability. At this point in time, technology has improved so much that we use microscopes, we use endoscopes, laparoscopes, etc., and we can adjust that to what the surgeon's eyes condition is. So LASIK surgery itself, or even refractive eye problems, whether it's short-sighted, long-sighted, irrespective, is not going to stop you from being a surgeon. Okay. To be very honest, I never used to wear spectacles until very recently, but I don't think that may be a better or a worse surgeon then or now. What is much more important is knowing when to do what to do in the most appropriate way possible. So no, LASIK surgery, refractive surgery is not a contraindication to become a surgeon.
So I myself aspire to become a surgeon, and I intend to train in the US. I saw the slides that you shared about the compensation. That was back in 2015. So the latest is somewhere around the median salary for neurosurgeon is around $750,000.
Wow. Okay. Thank you for updating us.
Yeah.
But yes. But this is not limited to surgery. Even though neurosurgery is at the top, most surgical fields, the median salary is much higher than the medical fields, and that is something I don't know whether it's the correct way, but that's based on the compensation you get due to the work you're doing. I guess it pays because of the you have paid in the really bad work-life balance you have had to go through during your training phase. But surgical fields always pay better. I think somebody has raised their hands.
Yes, Lorraine, if you have any questions, you can please put them in the chat box. I'll be more than glad to share with Dr. Vairavan. Okay, Dr. Vairavan, thank you so much for giving such a detailed discussion. I think we can move on to Dr. Vikas now.
Yeah.
Okay, thank you.
Right. Thanks, Ad.
Thank you. Dr. Vikas,
sure.
Please.
Hi, Dr. Vairavan. Glad to meet you online and hope to meet you in person sometime soon. Malaysia is a place where I visited only one. Incidentally, the airport is a crazy place to be in. So that's a big transit place. One is always forced to come to Kuala Lumpur for at least that reason. The university, of course, is a now good excuse to visit Malaysia. Welcome to Bangalore also to all of you, and specifically to you, sir.
I'm sorry to interrupt you in the middle. So let me introduce Dr. Vikas. Dr. Vikas is the professor of neurosurgery at National Institute of Mental Health and Neuroscience, Bangalore. He did his computational neurobiology at the Indian Institute of Science, Bangalore in 2005. He then went on to do his postdoctoral fellowship in cerebrovascular surgery in 2009 at Sri Chitra Tirunal Institute for Medical Sciences. He also did his master's in neurosurgery at the Sri Chitra Tirunal for Medical Sciences in 2008, and then went on to do his PhD in artificial intellectual cognitive surgical robotics in 2020 at International Institute of Information Technology, Bangalore. So that's a very stellar profile, Dr. Vikas. We'll be more than glad to hear from you about the awake craniotomy.
Okay, I think one of the reasons why I mentioned that I rather do my introduction myself is because of this very jumbled profile, which is incidentally there online. So I'll simplify it a lot more than that. Like Dr. Vairavan, I also spent a huge amount of time getting into neurosurgery because it takes a long duration of time to specialize. One, getting into neurosurgery and even passing out, doing reasonable amounts of surgery takes a large amount of time. Apart from that, I've had interest in computational sciences, which is the PhD, incidentally, is not completed. I'm still doing my PhD. So working in a national institute and working at one of the apex institutes in the country would sort of spur me to proceed further with research, which is one of our mandates of working in a large institute. So it's in that context that I pursue some stuff like that. Of course, it's basically predominantly interest-based. You need to have an interest in something and then you pursue it. You should have the atmosphere and the working environment to pursue interest, which I fortunately do have to some extent. So when Katir insisted that I speak on awake craniotomy, I had to think of how to go about it, because I understand that the audience is predominantly undergraduate, and you need to speak the right amount of stuff to undergraduate students. It has always been my emphasis that I present stuff as really happens, because to project something unnatural or unreal wouldn't serve the purpose. So it is in that context this entire talk is set. So I think I'll go ahead with the slide share. So awake craniotomy is again like Dr. Vairavan's topic. It's a niche area. It's a niche area because of very odd reasons. So there are people who are fanatics who are very fond of awake craniotomy, and there are people who would consider it as another tool in the neurosurgeon's armamentarium. I'm incidentally in the second part. Not a big fan of awake craniotomy. I do because it's something which I've been trained on, and there are very select cases in which I consider awake craniotomy. So as of now, I'm a professor of neurosurgery at the National Institute of Mental Health and Neurosciences. A brief idea about the institute where I work. It's a very large center. We are a combination of mental health and neurosciences. So it's a hospital setting with basic science research under one roof. So the focus is on mental health. So there's a huge psychiatry specialty with psychology and so many allied psychiatric sciences. In the neurosciences, we are three, that is neurosurgery, neurology, and interventional radiology. So you can see the numbers. They are very high numbers for a dedicated center like this. So we perform anywhere between 8,000 to 10,000 surgeries a year. Of varying kinds. Obviously, it is not that all of them are very big surgeries. We have 12 operating theaters which are dedicated for neurosurgery, 3 of which run 24/7 and 365. We have at least about 40 residents in training at any given point of time, and the residency program itself has completed 50 years. We are one of the oldest in the country. We take in about 10 residents per year. And since this audience is almost completely international, I would also invite people to come over here. We have, as I understand, sponsored this one, which can be sponsored through embassies of various countries. You can look forward to it. As a place for training, we are second to none in the country. There are equals. So that is because of very unique features, because we are faculty-wise, we are 6 strong. We would be increasing it to about 19 or 20 in the coming couple of years. So with the kind of resources which are available both in teaching and in patient care numbers, it forms a very formidable institute to which to train in and work. It is, of course, tough, like Dr. Vairavan said. I would be quoting him on several contexts throughout the talk. It's a tough journey because workload is very hectic. There's always the question when you get demotivated because of the surgical field. It's a very tough field in that context. It's very unforgiving. I think that's the term. Now, if you look at the larger context of neurosurgery in India, it's become a lot more simplified since the national entrance exams have come into being a couple of years back. So if you look at postgraduate degrees in neurosurgery, we have 2 streams as such. One is the MCH neurosurgery, and the other one is called the DNB neurosurgery, which have different examination boards. A more simplified understanding of this is there are governmental institutions and larger medical colleges which have the MCH. DNB is in smaller medical centers with neurosurgical facilities. So each of these streams have 3-year courses, which is after surgical specialization, basic surgical specialization. And there is also the 6-year course, which is directly after an undergraduate course in medicine. So these two streams are there. The examinations are fairly different from each other, but NCH is the traditional benchmark for neurosurgeons, sort of say. The DNB is a more newer version of certification for neurosurgery. It's there for many other fields also, incidentally. So having said that, I think I'll go on to the topic of awake craniotomy. The glamour associated with awake craniotomy, to my understanding, is because Roger Penfield discovered the motor homunculus on stimulating various parts of the brain and identifying that parts of the brain can be associated with specific functions and specific regions of anatomy. So you have the motor cortex, which in turn can be having localized regions which are responsible for hand function, limb function, speech, and various other areas of the brain which are localized, say vision, audio, language, and thought and other processes. Now, if you look at the development of surgery, advances in surgery have been in parallel to advances in anesthesia. So both of them went hand in hand. When anesthesia was very rudimentary, we had very rudimentary surgical procedures. I'm sure all of us would have read about the 30-second amputations, the surgery with 300% mortality, and they've happened. We have to acknowledge our own history as surgeons that these were things which had to be done at one point in time. But modern surgery sort of developed after techniques in anesthesia, fluid management, management of shock, all of these advanced, and that sort of continued until we went back. That we had to split the idea that the control of pain and the control of awareness could be split into two things. That sort of forms the basis of our ability to keep a person awake when we do brain surgery. So prolonged surgery requires lots of awareness and pain control, and the splitting of this is sort of the basis of performing awake craniotomy. Like Dr. Vairavan said, surgery on the brain is risky because neurological deficits are very, very unique. Small damages in different parts of the brain or the blood vessels of the brain or the coverings can result in large problems. So you can have a small deficit of under a centimeter located within the internal capsule, which can make a person bedridden for his or her entire life. Now, many of these are irreversible deficits, which makes the matter worse. So it has always been thought of that neurosurgery has poor outcomes, and generally the field did not have tolerance to mistakes, and that sort of was the reason why many of our teachers and the older people in the field were very difficult to get along with. Things have changed to some extent. Like Dr. Vairavan said, we've used microscopes, we use a lot of technology in our operating rooms, and we've tried to minimize the damage, but still the field is unforgiving. When things go wrong, they really do go wrong. So let me, as an undergraduate audience, I should introduce you to some concepts in brain surgery. I'll start with tumor surgery because that's one of the areas where awake craniotomies are used. And with the idea of what I present over here can be extended on to many other surgical concepts in neurosurgery. So many of the tumors which we handle in the brain are malignant tumors, and by rule, it is necessary to take out a tumor in toto. So you should be able to remove a complete tumor. And if you've heard about surgery in other parts of the body, there's this concept of en bloc resection. You take out tumor along with the tissue which it is encapsulated or covered in. Now, this doesn't work in brain because you do that kind of surgery, you end up in neurological deficits. And as I showed in the earlier slide, these deficits can become irreversible. And this indeed causes a dilemma. So whether you take out tumor or whether you protect the brain or the neural tissue. The ideal way to go about it is to ensure that the middle path is acquired, wherein you not only take out maximum amount of tumor, but also minimize the amount of neurological deficits which can happen. Now, it is in this context that the field has evolved. Neurosurgery as a field has evolved. So we've had multiple issues. So what is the problem in brain surgery is that we are not able to see what we are doing during surgery. That's the C part of it is a philosophical C in which you're not able to appreciate things which happen in the surgical field to a very detailed extent. You do see stuff, of course, but that is something. Anatomy in the brain is very difficult to perceive during the operative process. The second thing is, although you may be seeing, but what task you do and what damage it can cause is something which you are not cognizant of during the actual process of surgery. So if you look at it in this context, you'll find that two separate streams of development are there in neurosurgical technology. One of them is in the image guidance part, intraoperative imaging, in which we use different techniques to find out what part of anatomy is getting addressed at different parts of the surgery. So something simple like intraoperative ultrasound, in which we use ultrasound to locate the direction of a tumor or a lesion within the brain, and the depth at which it is there in relation to the brain surface it's an example. Image guidance, in which we take preoperative images, CT or MRI of the patient, and fuse it with the patient's imaging, patient's external surface markings during surgery, and then map the real world to the virtual world. So when you point to some part of the anatomy, you can make out what part of anatomy is being handled on the corresponding image. So that's about finding anatomy. If you look at the functional part of it, that's the physiological monitoring part of it, we have two streams again there. One is neuromonitoring, and the other is awake craniotomy. So awake is the oversimplified version, in which the onus is on the patient to report stuff to the surgeon that something is going wrong. The surgeon is actually evaluating the patient to find out whether neurological deficits are happening. Neuromonitoring is actually a proxy of the same thing, in which the patient is unconscious, but you do get electrical information from various parts of the brain and the spinal cord. Now, all of these have evolved. These have evolved over the past 20 to 30 years. And speaking of all of this technology in a span of a few minutes, you must understand that there have been a lot of roadblocks. There have been a lot of technological, insufficiencies which have prevented us from utilizing the full potential. But yeah, it's always a work in progress, and we work with whatever is available to us. So to make things clear, the notion of awake craniotomy is to help us live monitor a patient during the process of surgery. So the commonest place where we use awake surgery as of now in contemporary neurosurgery is deep brain stimulation. So most of deep brain stimulation, which is for Parkinson's disease and we need deep electrode placement, some of which is incidentally used in epilepsy, is in finding out the side effects caused due to electrode placement during the surgical process. Especially in deep brain, the tip of the electrode is placed in a very difficult area where motor fibers, visual field fibers, and various other fibers are very close to each other. So it's not possible to electrically monitor all these functions without the patient being conscious. So you need patient cooperation and communication so that we are able to actually place the electrode without causing permanent deficits to the patient in these particular areas. The other areas where this technique is used is obviously eloquent cortex surgeries. Eloquent cortex is functional tissue. So some tumor is on or around the motor cortex within the brain. You would prefer to do it awake so that you minimize the chances of the patient getting deficits due to the particular tissue being handled. Now, motor is one, speech is another. The difference between motor and speech is motor is sort of localized in the sense that you have cortex, you have the subcortical white fiber, and then you have the long tracts in specific areas, say, for example, the front of the brainstem. But speech is more distributed, so as to say. So you got the Wernicke's area, which is posterior temporal. The Broca's area is somewhere in the frontal, and the communicating fibers are deep temporal and across the insula. So that's more complex. And speech or language is something which you cannot actually get the data through an electrode. Our processing systems are not evolved to that extent in which you actually get electrical recordings which can tell you what kind of language area has been involved or is in close proximity to that surgical tissue. Cerebrovascular surgery, there are some surgeons who prefer to keep the patient awake during aneurysm surgery. It sort of gives them an idea as to how much of tolerance is there when part of the blood circulation is occluded during the process of temporary clipping. There are surgeons whom I know who use awake for AVM surgeries, because AVMs again have the same notion that they are mass lesions situated within the brain, and you have to excise them without causing deficits to damages to the surrounding brain tissue. Of course, there are short procedures, stereotactic procedures, gamma knife radiosurgery, small biopsies which are done, but generally they do not come under the complete idea of awake surgery. Awake surgery is something more complex than the relatively short procedures which are done, which as listed above. So to look at it in the anatomical perspective, you would look at lesions which are close to the motor cortex, lesions which are close to the language areas, and lesions which are sort of close to the visual fields. I use visual fields basically because DBS, which is the most common procedure which is done, a lot of effort is done to find out if the patient has got problems with visual fields. Visual fields in the sense movement of the eyes, and of course with field loss, visual field loss. Now, how do I go about telling something about awake surgery? The best way I thought is to actually showcase how we go through the process of an awake surgery. As a large center, it was fairly easy to find a patient appropriate who would fit the criteria to undergo awake surgery, and I did it as a prospective study, so as to say. Now, the fundamental ideas in awake craniotomy is neural tissue is pain-free. So though the neural cognition, that is sensations, are perceived by nervous tissue, the tissue as such is independent of sensation. So it doesn't recognize brain or the cord, or the nerves don't actually recognize any of the sensations when acted upon. Now, the other issue which I've already told you is the separation of pain relief from awareness, which is a evolution of anesthetic technique. So earlier anesthetic drugs, medications, gases would not be able to differentiate between the two. So somebody would need to have loss of awareness to have pain control, which we are now being able to separate. So the third important point is the patient best recognizes a neurological deficit. So somebody who is aware of deficit in progress is the best person to tell the neurosurgeon that something is actually going on. So for my illustrative case, I present a 60-year-old male patient. He presented with a duration of cognitive decline. He's highly trained, is an engineer. This is a gradually progressive disease which they have noted. Incidentally, they landed up with a psychiatrist thinking that it is dementia of some kind. Imaging showed something else. So he also had mixed aphasia. Unlike our clear-cut aphasia syndromes which we read in neurology and textbooks, patients who come to us do not have very well demarcated aphasia syndromes. So we had mixed disease, which I can show you in the imaging. So we've taken informed consent for recording the entire procedure and displaying it to this audience. I'll start with the imaging because you need to have, as I told you, the context is important. So this is a temporal lobe lesion. Dr. Vairavan already showed the margins of a temporal lobectomy in his epilepsy video talk. So this is a lesion. It's easy to recognize. It looks malignant because it's a ring enhancing lesion. There is peripheral enhancement and central hypointensity. This is an MR image. And in an elderly gentleman, the first diagnosis would be a malignant lesion. And looking at the size of the lesion, it would be most probably a glioma or glioblastoma. Now, some things are of interest here. It is I hope you are familiar with reading MRIs. So the left side of the image, the right side of the image is the left side of the patient. It's from below upwards, you see the image, and you can make out that it's a pretty large lesion, and there is something called as a midline shift over here. So there is a significant midline shift, and the lesion is quite occupies a significant amount of the brain. There is a significant amount of perilesional edema, which is this hypointensity which is seen surrounding this enhancing areas. Now, what parts of the speech areas are involved? I think I should show some of that. We start with the lowermost part. So the posterior temporal lobe. So posterior temporal lobe is the place where you would end up with the Wernicke's area. Remember that in patients with diseases, you can't have anatomical location. So you can't say that the Wernicke's area is exactly in this place. It gets displaced because of the disease. It gets displaced because of the edema. It gets displaced because of the damage which has happened due to the disease process. So you have the Wernicke's area somewhere close to the tumor, posteriorly. You also can recognize that there is this part of the temporal lobe which is herniated. This is the brainstem, which you can see is pretty much distorted. This is the normal architecture of the brainstem on the right, and it is distorted, and the tumor in the sense the temporal lobe is compressing. Going higher up, you can notice that it sort of appears as if it is reaching into the Broca's area. We will see that in the next image, but there is at least compression in the inferior frontal lobe, which is the location of the Broca's area. And the entire area connecting the Broca's and the Wernicke's is hypointense, indicating that the possible reason of this aphasia, the partial aphasia which he has. Now, so we go on to the subsequent image. In the sagittal image, we can see the same lesion. The extent of the lesion is obvious. You can see something over here. So this is the temporal horn. The temporal horn squashed downwards, and this is the MCA vessel which gets draped over the tumor. So the MCA is displaced superiorly. So that indicates that the tumor is predominantly temporal in origin and doesn't seem to be extending into the insula. So the location of the insula is another thing which we need to look at for this particular patient. So we proceed with the coronal image. The coronal image shows the same nasty stuff. It incidentally in this section, you could look that there's a part of frontal involvement, but if you look posteriorly, we would actually realize that is just the displaced Sylvian fissure. So the Sylvian fissure is located superior. So we now have an elderly gentleman with an enhancing tumor, and the location of the Sylvian is superior. So we do not have tissue which is going into the other lobes. It's confined to the temporal lobe, and the treatment which can be offered to the patient is decompression of the lesion. Now, the term decompression is used for most intrinsic brain lesions because you are never sure that you can take out the complete tumor at the end of surgery. The idea is always maximal safe resection. So maximal indicates that you can tend towards taking out the complete tumor, but you may never reach the completeness. Safe resection indicates that you will try to preserve normal tissue as much as possible. So those are the issues which I would like to point out in this patient. And then we'll proceed on to the next step of surgery. So this is imaging, clinical presentation, and speech is involved, right? So that's the reason we thought about proceeding with awake craniotomy. Now, a little more explanation. So you have lesions in the motor cortex. We can always use cortical monitoring. So cortical monitoring is you provide stimulation in the cortex, motor cortex, and then check the stimulation at the distal muscles. And there are certain muscles in which you put the electrodes and get the signals. So you can sort of have recordings which will help you to say that there is damage or no damage happening to the motor fibers during the course of surgery. as I explained earlier, it's not possible to do with speech because you can't have electrical recordings which give you the same quality of information. There are, of course, proxies which can be used, but the quality of information is not available. So speech is just about the only kind of indication which I use for awake craniotomy because of some other issues which I'll discuss later. So we made a plan for a left pterional craniotomy and decompression. A pterional craniotomy is something, craniotomy which is centered around the pterion, and decompression, as I told you, is we take out part of the maximum part of the tumor as explained. Awake craniotomy, we also use neuromonitoring in parallel, and QSA is the major tool for handling the tumor. Personal preference. The surgeons who use different kinds of tools for their taking out the tumor, I am a strict QSA fan. So anesthetic consideration. So a major part of awake craniotomy effort is from the anesthesia side, because not only they have to take care of the patient during the entire surgical procedure, but they also have to make the patient amenable to interrogation from the surgical team. So what is happening? So that forms a challenge for the anesthesia team because they have to ensure that the patient is in that right so-called Goldilocks zone for doing that purpose. So what I'm doing right now is I'm taking you through to our anesthetist colleague who explains the procedure which we did for this particular patient.
Dr. Vikas, the audio isn't audible, I think.
How do you do that?
Kathir, can you help us with that?
Yeah, in this minute.
I think there is a share sound.
Yeah, then we have to click that option.
Yes, so I'll start from the back and.
Hi, I'm a neuro.
Is it there?
Audible, sir. Yeah, it's now audible.
Yeah,
but and I'm here to tell you
Zoom
about the conduct of anesthesia for the procedure of awake craniotomy. Normally, when a patient with brain surgery undergoes anesthesia, we give him general anesthesia where the patient is fully unconscious and he will be under the state of anesthesia till the end of surgery. So how do we conduct this anesthesia? So patient is usually given an intravenous anesthetic. It may be the thiopentone or propofol, and he'll be made unconscious along with an opioid analgesic. And then we give him a muscle relaxant which paralyzes him, and then we intubate the trachea and then connect him to a workstation ventilator to connect it to an anesthesia machine. So this will continue. The patient's trachea will be intubated and he will be on ventilator till the end of the surgery. So the maintenance of anesthesia can be done either with an inhalational anesthetic, as you would have heard of sevoflurane or desflurane, or sometimes a propofol infusion is also continued for the maintenance of anesthesia. So once the surgery is completed, the anesthetic agents are cut off and the patient is reversed from the procedure of anesthesia by giving a reversal, and then the patient is made awake. And once the recovery is complete, the patient's trachea is extubated and the patient can now communicate with us verbally and talk, and then we can find out the absolute recovery of the patient. So when in a patient, when we already know the brain tumor is near some important brain area, like the area of the brain which controls speech or the movements of our limbs, a precaution can be taken to prevent the damage to these areas by doing the procedure under awake conditions. That is, the patient is awake to tell us that a complication is likely to happen. Now the patient is not awake throughout the procedure. He is awake only during a small amount of the procedure. Let me explain to you the awake craniotomy and the anesthesia, how it is done. So the first and the foremost thing is the patient has to be explained that he is going to undergo awake anesthesia. And the entire procedure, which I am going to explain in the next few minutes, has to be told to the patient so that the patient knows what to expect and he should be ready to cooperate. So what is done, once the patient is informed and the consent is taken, we take the patient inside the theatre. We start a low dose of sedative medication, which is most commonly a dexmedetomidine based sedation, and patient is put to light sleep. patient is not made unconscious like in general anesthesia, but is given light sleep. Along with that, we may give a small dose of analgesic, can be an opioid. So once the patient is a little asleep, we give him scalp lock. Now what is scalp lock? Scalp lock is anesthetizing the scalp area where we block multiple nerves of the scalp around the forehead like in a circle. So the nerves which are blocked are supratrochlear, supraorbital, zygomaticotemporal, auriculotemporal, occipital and auricular nerves. For each nerve we give 1 to 1.5 ml of local anesthetic. So this will ensure that the patient does not have pain during the craniotomy and the conduct of surgery. So once the scalp lock is completed and the intravenous lines are taken and the anesthesiologist is done with his procedures, the next comes is the positioning of the patient for the surgical procedure. At this time, we should make sure that the patient is fully comfortable and all his comforts have been taken care of, his neck, shoulders, his lower limbs, everything is properly padded and he is fully comfortable for positioning. Once the positioning is done, again the sedation continues as such, and till the point when the surgeon is ready to operate on the tumor, the patient continues to be sleeping. So we titrate the anesthetic medication in such a way that when the surgeon is ready to operate on the tumor, at that time the patient is fully awake and alert and communicable with us. So now the surgeon starts resecting the tumor bit by bit, and simultaneously we keep talking to the patient to see his speech, and we also ask the patient to move his limbs so that we know if there is any damage happening to these areas, the surgeon can immediately stop and prevent further damage. If the patient is talking and the patient suddenly stops speaking, the surgeon is alerted that this is the speech area and he will move away from that. So like that, we can preserve the important areas to the brain by keeping the patient alert and awake and communicable. Once the surgery is done, once the tumor has been resected, now the patient need not be alert and awake, and we start the sedative medication again and the closure of the surgical wound starts. The patient is asleep till the surgery is completed. Once the surgery is over, we again stop the anesthetic medication and make the patient awake and communicable. We know now that there is no complications happen because we have tested the patient after the surgical resection. Now the patient is awake, alert and can be moved out of theatre. There are certain things we have to be careful while doing this kind of anesthesia procedure. The patient may have sometimes minor discomfort during the procedure, and we encourage the patient to speak out if he has any discomfort, and we can at that time point we can address his concerns like placing some shoulder support, or sometimes a small dose of analgesic can be added at that time point. So this is how the anesthesia for awake craniotomy is done. I hope you understood how it is to be done, and I thank you all for your patient listening.
Yeah, so we go to the actual surgical video. So what you saw was what was done for this particular patient, and you saw, I think since it's an undergraduate audience, you should know that brain surgery is often performed on fixed head. So you saw the head being fixed with a Mayfield clamp. It's a 3-point fixation, rigid fixation, so that the patient is not moving during surgery as such. So these are some things which are very unique to neurosurgical procedures, and I thought you should get a feel of the neurosurgical process in its completeness. So we start with the next video. I think again audio is it's audible. So we start with the craniotomy. You can actually hear the craniotomy done when the patient being conscious. So this is actually to show that pain control, how much of pain control we've been able to achieve can be seen through the process. So that is, I think I should introduce my surgical colleagues. That's Dr. Amrita and Dr. Nadeem, who had assisted during the surgery. They are residents of NIMHANS, and they've been part of the surgical procedure. So you are seeing the temporal terional craniotomy. That's the temporal burr hole, it's a burr hole which is being made at the lower part of the temporal bone. We use burr holes which are connected by cuts to take out the bone, take the bone out. And as you saw now, the patient is completely awake.
Hi, yeah.
So the patient is actually from a very distant part of India. It's the northeast of the country, and he speaks. He's an engineer, but his native language is something very specific, very unique to that particular state. Now, it is important for somebody to interpret in the mother tongue, because the mother tongue is the easiest language for communication during the surgery. So we got an interpreter, fortunately, within our student group, who could interpret the patient communication during the surgery, and you can actually hear her talking to the patient. What I would like you to observe during that is not to look at it as something which is happening, but understand the difficulties and the issues which are there. I will discuss those issues at the end of this procedure. So awake craniotomy, I would want you to have a practical understanding of the topic rather than just some textbookish version of the same. So the idea of actually showing you a procedure is that is to observe, and let's hear your comments later on. Okay, so that was the preliminary assessment that is done after craniotomy. So to find out what is the patient's level of comfort and any issues which he has during that. It is actually not an assessment. It is just to ensure that his cooperation continues during the real part of surgery, where his cooperation is very essential. So this is the dural opening. You can see the brain coming out through there. Some bit of orientation. I understand this would be a naive neurosurgical audience. So this is how brain tissue actually looks like. It being a surgical field, you can see cotton patties which encircle the surgical field. So you're not able to see the dura at the outer part of the surgery. This is the temporal lobe. I'll show you the orientation in a couple of seconds. You can see tissue over here, which looks pretty different from the tissue over here. So that's the tumor which is peeping out through the temporal lobe. This vein is important. This is something called as the vein of Labe, which is important for temporal lobe resection. So you will get the orientation with the annotations which you can see on the screen. So patient is not exactly supine. Patient is supine with head turn. So one more assessment. We are actually preparing for something called as, we'll start with the electrocortical stimulation of the Broca's area. So Broca's area is in the frontal lobe. And the response which we anticipate is something called as speech arrest. Though the Broca's area is the output area of the language for the brain, stimulation of the Broca's area actually causes speech arrest.
Makadi? 3 ki Makadi? Keep repeating 1, 2, 3. 9 Makadi? Stimulating now. 9 ki Makadi buba.
So that's a bipolar stimulator. This is approximately the part of the frontal lobe which will be the Broca's area. This is the Sylvian fissure. This is called as the pars triangularis over here, and that's the area which is getting stimulated. The first part of the stimulation, you would hear a beep sound which indicates electrical contact and that the circuit is complete. So we'll see the response.
9 Makha hero 9 Makha. Why is tired? Why can't you but do you buy go what is high late at the operation that over there? 9 Makadi. 1, 2.
Okay, back to the surgery. So that sort of was an idea of speech arrest, but that's the issue. See, to get the exact location of the Broca's area in a patient would be difficult because you do know the approximate region where the Broca's area is, but for different patients, the responses may be different. And secondly, the patient is somebody who is suffering with the tumor. So there is a lot of displacement, edema, the anesthetic agents, his age, the stress of, somebody doing surgery on the part of the body, all that counts. So orientation is like this. So anterior is this. This is the anterior part of the temporal lobe. Inferior towards the leg. Superior, this is the frontal lobe over here, and posterior, which is the posterior part, which is the Wernicke's area somewhere in this region. So that is there. A standard temporal lobectomy, meaning this is how I've been taught. So this is the subpial, the pial incision which is being made on the temporal lobe, close and parallel to the vein of Labe, so as to say. It's not very important in this particular patient because all of the temporal lobe is going to be get resected, but in other patients, we are supposed to be careful and protect this vein of Labe. Okay, so that's the pial coagulation. Proceed with pial incisions. So that's the pia being cut. You can actually see the pia being cut. That's the Sylvian fissure. So the landmark, meaning the landmark which you need to keep in mind during the subsequent parts of surgery is that. And see, all of this surgery is performed with an operating microscope. This is a Pentero 800, which is one of the newer microscopes which is there in the market. Here you can see the CUSA in action. You can see that brownish tissue. So that brownish tissue is what is high-grade tumor. You can distinctly make out the difference in color. You can also make out it is bloody. There is some fluid coming out from the cyst within the tumor, and that is how you actually recognize tumor tissue. You can also, if you closely observe, that there is a little bit of white tissue which is on the surface, and which indicates that it is still a deep tissue and not completely surfacing on the brain. Now, why I'm a fan of CUSA, you just saw a blood vessel which is being handled. So I use CUSA to dissect tissue, separate blood vessels, do subpial dissections. That's a temporal artery which has come into focus. So next part of the surgery is the separation of the tumor from the Sylvian fissure. Sylvian fissure contains the middle cerebral artery. So taking out tissue from there is a bit tricky because you shouldn't damage the blood vessels over there. Blood vessels which supply to the entire left hemisphere, both the temporal, frontal, deep part. So all of those vessels are there, and that is incidentally the middle cerebral artery. So this pinkish structure over here is the middle cerebral artery exposed partly through the pia in the Sylvian fissure. As we go posterior, this is insula. So this white tissue over here, which you can see beyond the pia in some places and through the pia in some places, is going to be the insula. So that would make that this part which is being taken out is the temporal operculum. The temporal operculum goes over the insula and covers the insular surface. So you can see tissue being taken out. This is dull in color as opposed to brilliant white. Of course, this is through a camera, so you wouldn't be able to appreciate the complete details. You're welcome to come here and join neurosurgery. So what about our assessment? So this part of the surgery where we are doing our assessment is it's after the completion of the Sylvian fissure dissection. So this is one of the places where damage can happen, but yeah, you use it as a landmark to assess. So we see what happens. Nothing happening in the operating field.
No, it's wrong. The number keeps on mixing. Then.
So there is some change in contrast to the initial assessment. But yeah, I'm sure that I've not done anything which should cause damage. And besides, that jumbling of numbers is actually not something I expect from a damage in this area. So that is something which I would expect in the posterior superior part of the resection, where the Wernicke's area is there, or the conducting fiber, the fibers which connect to the Wernicke's to the Broca's area. So that is a place where I would expect that defect. So that doesn't correlate. I continue my surgery. Next part of the surgery, which I show you here, is sorry. Where did I? Yeah, insula over, and we've come over here. So this is exposure of the should be exposure of the uncus. So uncus is the medialmost part of the tumor. So another landmark, I think it's a bit mixed up. So this is another landmark where you would actually check for the patient status. and we do the assessment again.
Baba kaidoge ba? Ha? Kaidoge harog na braba? Kaidog kay nungay taga harog? Nungay chida harog ba tayo? Ha? Lang ba yadi?
He's talking, but he's not making sense. It's not comprehensible.
Kay nungay taga harog ba?
See, this is one of the issues. You dissect in the area of this damage. There is always handling which happens to the fibers. You may not be damaging the fibers. So it's always a surgical call to take whether, you should stop at that part. Now, that is something I'll discuss in detail at the end of this video. We'll see what happens subsequently. So, progress. Yeah, so this is the uncus which I was telling you about. So uncus is important because that is what is herniated beyond the tentorium. So the brainstem goes through the tentorial incisura from the what is that from the hemispheres, and then it goes into the posterior fossa. Now the uncus is part of the temporal lobe which herniates across the tentorium and causes, you must have heard of the uncal notch and things like that in postmortem studies. So the uncus compresses on the brainstem, and that is actually what threatens the life of the patient. So uncal resection in this case is very important, and it's also risky because of several things. One is the brainstem, which is millimeters away from the uncus, the internal carotid artery, and the anterior choroidal artery, which goes from the internal carotid artery and goes into the temporal lobe. So damage to any of these structures, and you are sitting with hemiplegia. So here, what is being shown is you can make out this is the uncus. At the later, a little bit more, you would start seeing the internal carotid artery, which is one of your landmarks. So that cylindrical structure which is seen here, this structure is the internal carotid artery. So that's the internal carotid artery. The yellowish structure which you see behind, that is the brainstem. So brainstem, carotid artery, and slightly down, actually, you see a part of the posterior cerebral artery, posterior cerebral artery. I couldn't make out the PCOM, that is the posterior communicating artery in this section. Part of it is because the camera has been oriented like that. So this is slightly lower down. You can see the tentorial pia. So most of the resection, it is ideally done subpial, which is what is being shown over here. But in tumors like this, it's very difficult to maintain the subpial plane for extended periods of time. So that's part of the problem. So we've finished most of the anterior part and the posterior part, and this is at hemostasis. So tumor resection is complete. We have proceeded through the tumor in spite of issues which the patient has been reporting. Remember? So there's some information which I've got. As a surgeon, I know that the patient has been communicating throughout the procedure. The patient already had speech deficits, which I have to compensate in my understanding when the patient is not able to do something fresh. So when there is report from the psychologist side that the patient is not able to communicate properly, I take an operative decision. I take an operative decision as to whether the tumor which I have to take further is diseased or not. So that is something which has to be done. Now, let's see what happens at the end of hemostasis. We take another recording. We talk to the patient once more and find out. This is a clearing up field.
Numbers. And let him repeat.
Loidore baba ko ado haijat ningi ko aina haijat ang hello ko amma baba haro amma baba loidore baba tabra baba tabro baba nipangi ko amma haro amma loidore ning atang hari amma Antang hai sila. Tabro ba?
You can hear me, he opens his eyes, but Something like. Yeah. Please tap and see.
Tabra ba? Sharat? Buba, tabra. Ay na haisam tang halo. Ama, loidore. Ama? Ani? Loidore. Ani? Haro, ani? Ahum? Mari? Mga? Taruk? Taret? Nipan? Mapan? Tara. Yeah.
Okay. So,
Babae ming do kay have no. Sarat hay bra. Chumbra. Chumbra lan bra hay ro. Ha? Ming do sarat hay bra chumbra. Ha. Chumbra ba lan bra ba. Chumbra hay ro ba. Sarat ko bra ba ming de. Sarat ko bra ba ming de. Chumbra ba. Chumbra. Chumma. Chahi kya ba? Ha? Chahi do?
Yeah, name he said it's right. Here I asked like. So his eyes are open.
Chummi ko. Sarat chummi ko.
That part he said like name. Can you repeat?
Ay ka mutang ka tawar siya doon tumadan. Kaya ko? Batong ginu ko. Tumit kang turo ba? Hindi kang turo. Diba? Kaya ko, ama.
No, it's like falling asleep again.
okay, so that sort of gives you an idea of what actually happens during an awake craniotomy. So this is it may not be, you have various versions of it. Say, for example, if it is not a tumor, if it is something like unruptured aneurysm, the patient is more conscious. If it is a smaller lesion in the motor cortex, the sensorium is not much affected. If it is younger, the patient may be a bit more cooperative. Anesthetic agent response is different because there is a certain amount of sedation which is going on, and it is very patient centric. You can to get that fine balance between getting good pain relief, which is the objective of anesthetic medications, and keeping awareness intact is a very fine balance, and that I think you get a feel of what is happening. So we go to the post-op imaging. So he was not cooperative enough for a MR imaging. So I have his CT. You can see the operative site, which is fairly clean. This whitish stuff is blood which is attached to that pile surface, and I presume it's a good resection of the tumor. You can see that the midline shift has decreased. There is air in the this one, and clinically the patient is doing much better. Incidentally, his speech has significantly improved when compared to the preoperative status. So let us revise what's happened during the process. So one is early recognition of deficits. So when something has happened, you get to know that something has happened, and that can be done intraoperatively. So you can use judgment intraoperatively. You can have more refined judgment as to what needs to be taken out next. But let's look at the disadvantages also. Patient cooperation. Now that is something which you do not have in your hand. You see very conscious patients once they go under anesthesia, once they are in a surgical procedure, may change. It depends upon the psyche of the person. So that is not something which you can always have in hand. So there's a lot of unpredictability in the sense that you can't depend upon the patient being awake to doing proper surgery. So that's a key take-home point. Now there is here sedation. So you have to look at those two things. So how much are you depending on the awake part of the procedure to determine how much of deficits is happening versus patient comfort? You keep a person fully conscious but give a lot of pain. No, that's just not right. So so how much of what is actual damage? You saw during the procedure that the patient was, the interpreter very, very openly says that the patient is incomprehensible. And it as medical person, we understand that, incomprehensible is damage to the posterior part of the speech areas, which is incidentally the most difficult part for this particular patient. Now, this is short duration surgery. The total surgical time was just about 2.5 hours, 3 hours. So what happened? I'm a very slow surgeon, so many of my surgeries usually go to 6 to 8 hours. So can you think of somebody lying like that and being cooperative during the entire procedure? So that becomes difficult. Now that is where this particular issue comes. How do you? There is the problem of the frequency of surgery versus the frequency of evaluation. You saw in the video that I've taken just about 3 or 4 recordings, which is the formal. There have been in between talks which I've edited because it's not very relevant. But you can imagine that the person was not talking for the entire duration of 2.5 hours. It's not necessary, but to switch on and switch off at relevant periods is difficult. Now, if we extend it to the surgical procedure as such, at what steps do I stop? One slice or one slide of the CUSA across tissue. Do I stop at that? Ask the patient, reevaluate the patient. It would become a never-ending surgery. But if you do something and then there is a deficit or the patient does not comprehend, is not able to respond properly, what is your take on it? What do you do? Stop at that place. Say that, yeah, patient has already started deficits. We are not going to proceed further. So there's a lot of operative judgment which comes in. Now, how do you classify that? So you have tumor area and then there is deterioration in speech. Like say, for example, what happened in this particular patient. So I would proceed with tumor resection. There are people who may differ with me. There is a doubtful area. It doesn't look exactly like tumor. It looks like edematous tissue, which is, so-so. And so there you have to take a lot of other factors. So you have to take up, say, there's already some doubt of deterioration, or I'll put it that way. The patient was perfectly normal before that. You start taking out a doubtful area and there is an objective change in the speech output after that. Then you're in normal tissue. It's easy. But doubtful area is doubtful even after some of these exercises. But what happens if there is a process change? Say you're doing something somewhere, like I was dissecting in the Sylvian fissure, there is a loss of comprehension in the patient. It doesn't correlate at all. So those are places where you take firm surgical decisions. Ultimately, what I'd like to point out is awake craniotomy is something which is an adjunct. It helps you during your surgical process, but decision making is something which is very unique to the surgeon, and you have to take a call at every part of the surgery. So in conclusion, awake craniotomy is a useful adjunct. Judicious use of the technique results in satisfactory results, both for the patient and for the doctor. Remember, it's not an exercise that I did so many awake craniotomies. The patient does have issues at the end of it. It's a fairly uncomfortable procedure. I'll give you a simple exercise. Try tonight when you're lying down to keep your hand in one or your neck in one particular position and lie down for half an hour. It's a very difficult thing to do. So it's just not a cure for all neurosurgical problems. The neurosurgery has this problem that we do not understand when deficits happen. So awake is not the only solution to that. It's always a mix of various kinds of options which are available with technology. It is still incomplete. We are not perfect. There's still a lot of stuff which needs to be done, and we are open to change. And incidentally, that's one of the reasons I'm talking to the next generation. Thank you.
Thank you, Dr. Vikas, for giving such a detailed insight into the awake craniotomy. I have myself had the chance to witness a procedure where the patient underwent awake craniotomy for a tumor. I was fortunate enough to be a part of it. It was, in fact, the first ever medical rotation that I did, and it was an elective rotation. I did it at Khan University. It's next to Liaquat National Hospital that you were earlier talking about.
Okay.
So Dr. Athar Inam is the head of surgery, neurosurgery at Khan Hospital, who was performing the procedure. And I completely agree with the fact that having the patient in that position and the compliance is very important for this surgery. So thank you so much for sharing these insights and this practical video, which I think helped a lot of students to get the idea of what awake craniotomy actually is. I think there was a question in the chat box for you. It was It was that, sir. How would you differentiate which AV malformation would benefit more from awake craniotomy and which would not?
Anything which is close to speech. See, as I told you, it's as a matter of policy, I don't do awake craniotomies for motor cortex lesions, very motor cortex or sensory cortex lesions. I use monitoring, subcortical monitoring. Even that has its problems. But speech is something which you cannot get through these things. There are some newer electrophysiological techniques which are not used as of now. I'm not yet I'm not being exposed to that. So AV malformations, exactly like tumor surgery, has the same principles. You have to take out the entire AV malformation and protect the cortex. And incidentally, the boundaries are much more narrow, because the gliotic plane around an AV malformation is too small, and sometimes it becomes really difficult to differentiate it from. So there is one of my teachers, incidentally, uses awake craniotomy for AV malformations, which is why I'm aware at least. So the concept is the same. See, there is some mass lesion which is surrounded by eloquent cortex. And when the patient is awake, you can take your time out to assess whether you have done damage or you're about to do damage to some part of the eloquent cortex, speech especially. So I hope that answered.
Yes, I think it does. So thank you, Dr. Vikas and Dr. Vairavan, for giving such a detailed discussion on your respective topics. And thank you on behalf of the IASS and its members that you took out the precious time and gave us this detailed discussion. So if anyone has any questions, they can still put it in the chat box. If there are none, I think we can proceed to concluding the session. So on behalf of the International Association of Student Surgical Societies, IASSS, I would like to thank you, all of the participants, for your interest and your support in the event today. We hope that you learned a lot, and if you're interested in attending more seminars, we will be having more soon. So make sure that you don't forget to register at IASSS as a member. So thank you once again. We wish you all the best and see you all in our next webinar. Thank you, Dr. Vikas. Thank you, Dr. Vairavan.